Good evening, everyone, and welcome to the 22nd episode of E-Gurukul, a successful series of surgical skill transfer and solving the clinical dilemmas by a stalwart gynecologist and a passionate teacher, none other than Dr. P C Mahapatra, sir, who is inspiring many young minds in the field of gynecology by sharing his valuable experience he gathered throughout his career. So, welcome, sir. And today's topic is also very important. Uh, so, today's topic, he is covering an important topic, that is the perioperative shocks in obstetric and gynecology, solving clinical dilemmas, tips and tricks. So, without wasting much time, I will hand over the session to Dr. PC, sir. Welcome, sir.
Thank you, Sanjay, and the whole team of Juventus in the E-Gurukul program in the series. Now, I welcome all my viewers. I welcome all my viewers to this episode of E-Gurukul organized by Juventus. And this is the episode 22. And this initiative, as we know, we have a theme, surgical skill transfer and solving the clinical dilemmas, and focused particularly on a different subject. And today's topic will be something different. I bring greetings from the place of Lord Jagannath as usual and start this 22nd episode before all of you, my viewers. And this episode is mainly focused on perioperative shock in obstetrics and gynecology. Well, purposefully, I have designed and focused this particular aspect because I have experienced shock. Everybody must have experienced both in obstetrics and gynecology. It could be varieties of origin, the varied etiology could be there, but experiencing shock in the perioperative period, all of you must have experienced. And once shock is there, you are also shocked. And just call for help and transfer to the ICU or intensivist or some other persons who are expert in management of the shock. I think today I must tell you that you are part and parcel of that. The job is not to transfer your patient to somebody else. You have some duty in this particular aspect where you can have a preventive strategy or a preventive surgical procedures to avoid a shock. That's number one. And if at all there is shock in the intraoperative period, you find some of the maladies you can tackle then and there. And after the procedure also, if you find something related to the surgery or associated with the surgery, you yourself can tackle much better. So therefore, have a comprehensive and basic understanding of shock is essential for all general gynecologists and obstetricians. They cannot ignore this, one should not ignore this particular concept. And this is a very integral part of all clinicians practicing obstetrics and gynecology. You may not be an intensivist, but at least you can do a lot of job in the phase of prevention, and in a decompensated phase, you have a right to treat that without the help of the intensivist. Beyond that, of course, you need help from other people, you need that. And therefore, the understanding of the shock in perioperative period is absolutely mandatory. And that's why I thought one special episode I will make it. This episode is dedicated for that. Now, what do you mean by shock? The definition. When I come across this, starting from the Webster dictionary to the medical dictionary to the various literary definition of shock to the scientific definition of shock, this is variable. Basically, this is some maladjustment between the demand and supply, maladjustment between the normal physiological homeostasis, or something related to the either a vascular or an infective or some of the cardiac cause, whatever it may be. But I will just simplify it, the definition, by saying that the best simple scientific definition of shock is a state of organ hypoperfusion. Ultimately, this is a state of organ hypoperfusion that you must understand as a man of science. And this hypoperfusion in the tissues is important. And there are two things at two ends. One is at the pump, circulatory pump, the heart, which pumps the circulation, the blood to the different tissues through the vessels, the capillaries, and they deliver the oxygen to the particular cells. And once there is a disturbance between these two ends, either in the pump or in the peripheral part in the vascular resistance, the cascade of events took place in the cells. And then the consequences could be devastating. That's the basic understanding of what a shock means. And therefore, the consequences, once the tissue perfusion, hypoperfusion occurs because of this circulatory disturbance, either because of the pump failure or because of the problem in the peripheral vascular resistance, the tissue anoxia occurs. Cellular energy injury occurs, oxidative stress occurs, and a cascade of inflammatory response occurs. A series of inflammatory response syndrome, shock-induced inflammatory response syndrome occurs. Or if it is more advanced to the decompensated phase, a multi-organ dysfunction occurs, MODS, and the problem, the tackling is much more difficult for that. So therefore, this basic physiology of the shock and impact of the tissue effects, this is divided into either a reversible phase or an irreversible stage. And as a clinicians, we must take an apt step at the reversible stage so that the mortality can be really prevented for that. And if it goes beyond a irreversible stage, I think by the time the vital organ, the brain functions deteriorates, you cannot save the patient. And therefore, the prime important part before the clinicians is recognition and early intervention. And that is why you are important, that you have to recognize it early and intervene in the right moment, whether it's a medical intervention or a surgical intervention. And that is the main purpose of a clinicians. Now, categories of shock. This is very important that the Society of Critical Care Medicine has become very, very analytical and scientific in formulating and dividing this into 4 different basic categories: hypovolumic, distributive shock, cardiogenic shock, and obstructive shock. These are the 4 main varieties or categories of shock in which the treatment modalities, the manifestations, the diagnostic criteria, and the physiologic response is completely different for that. Now, the hypovolemic shock, the causes in obstetric gynec practice, hemorrhage. We know that hemorrhage, bleeding, obstetrics is a bloody business. And when it culminates in hemorrhage, it's a bloody business. And therefore, either in obstetric hemorrhage or in hemorrhage due to gynecological surgery, comes under the hypovolemic type of shock. Apart from it, the dehydration, hyperemesis gravidarum, the GI losses, these are also the hypovolemic study. If it's not a blood loss, it's a plasma loss for which the same manifestations will be there. Second important variety is an obstructive shock. The brightest example of obstructive shock is a massive pulmonary embolism, cardiac tamponade, tension pneumothorax. These are all obstructive shock where this affects the cardiac pump and then secondary cardiac failure occurs. It's not a primary cardiac etiology for that. Third is distributive shock, the adrenal deficiency, insufficiency, the sepsis. The septic shock is the brightest example of distributive shock, anaphylaxis, and drug reactions. These are related to the volume, but the intracorpuscular volume is transferred to extracorpuscular spaces, and therefore there is a variation of the different parameters and tissue perfusion. Last is cardiogenic shock, peripartum cardiomyopathy. The primary cardiac or pump failure is there. Myocardial infarction, stress-induced cardiomyopathy, constrictive pericarditis. These are all examples of cardiogenic shock. Let us analyze all these. What are the diagnostic criteria? When the patient features of shock, what do you mean by features of shock? They are divided into three different varieties: clinical features criteria, laboratory criteria, and hemodynamic criteria, out of which the only most important is the clinical criteria. The tachycardia, feeble pulse, hypotension, cold, clammy skin, oliguria, altered sensorium. As we know, these are all known to all of you. These are fundamental clinical criteria of shock. May it be following delivery or following surgery in gynecological operations. Two other criteria is the laboratory criteria. This is the sequence of events secondary to the hypoperfusion on the cellular damage, the energy and the oxygen requirement. There is a derangement in the cells and there occurs anaerobic metabolism, resulting in the lactate and base deficit. So the lactate and base deficit are the laboratory criteria of shock, which not only aids to the diagnosis, but a measure to assess the tissue perfusion. So that is important, assessing the tissue perfusion by lactate or base deficit by the laboratory criteria. And of course, the hemodynamic, you measure it through the Swan gauge catheter or transthoracic echocardiography. These more invasive procedures of hemodynamic procedures, either with the central line or with the different pressure, the pulmonary arterial wedge pressure, you find out the systemic venous pressure, the mixed venous pressure, saturation, oxygen saturation. These are all can be measured by these hemodynamic invasive procedures. Now, a little bit about the details of these different types of shock. The hypovolemic shock, as I've told, hemorrhage is the primary thing. Rarely we find a GI losses and dehydration could be attributable for that. And this hemorrhagic shock, every one of you, including me, have observed for the last so many years about the different indications and the spectrum of this particular hemorrhagic shock, both in obstetric practice and gynecological conditions. And we have seen the two types of hemorrhage. One is a concealed hemorrhage, another is a revealed hemorrhage. A revealed hemorrhage is diagnosed much earlier than the concealed hemorrhage. So you have to, the mind should be very towards the concealed hemorrhage to identify. And if there is a concealed hemorrhage which is delayed, then it will cause more fatality and give rise to the advancement of from compensated to decompensated field. So the concealed hemorrhage is important. Say, for example, the abruption, placental abruption, or a concealed hemorrhage following a surgery, or a concealed hemorrhage following a tubal rupture. These are concealed hemorrhage, which you have to think about that on the clinical parameters for this. And of course, lastly, the hypovolemic shock, as far as the management is concerned, as far as the diagnosis is concerned, as far as the prognosis is concerned, the degree and class is important. You have to classify that into the various degrees. And fortunately, this critical care society of medicine has of late in 2016, they've modified into these different classes of hemorrhagic shock, which has simplified the clinicians in not only diagnosing, but assessing and finally formulating the line of management. Now, they have divided into 4 different classes depending on the blood loss. And depending on the blood loss, the class 1 is less than 750 ml in an average 70 kg. Or the percentage wise, if you calculate, is 15% less than equal to 15% of the total blood loss. Volume depletion is class 1. Class 2 is 15 to 30% or 750 ml to 1500 ml. And class 3, 30% to 40% and 1500 to 2000 ml. And class 4, more than 40% depletion and more than 2000 ml of blood in an average 70 kg. So this is the amount of blood loss, will say the different classes, class 1 to class 4. And what are the criteria? In the different classes, there are various components you diagnose and level it as this particular shock is of class 1, class 2, and class 3 or class 4. The various clinical criteria: pulse rate, blood pressure, pulse pressure, capillary refill, respiratory rate, urine output, and the mental status or sensorium. These are the different criteria by which you can know, you can assess the class or degree. And depending, once you find out the class, the prognosis and the management can be defined well. Say, for example, the hemorrhagic blood loss, the treatment is replacement, volume replacement. Now, in the volume replacement, it's not that always you have to replace with the blood. In class 1 and class 2, you can replace crystalloid and recover it and arrest the bleeding at the same time. Whereas in class 3 and class 4, along with the crystalloid, blood is necessary. Simple crystalloid is not a solution for that. If you go more details into the different criteria, you can find that in class 1, pulse rate is less than 100. Class 2 is 100 to 120. Class 3 is 120 to 140. And class 4 is more than 140. And blood pressure in both the class 1 and class 2 are normal because it's a compensatory mechanism in the hemodynamic. And the blood pressure is maintained by increased peripheral resistance, systemic vascular resistance, cardiac output is maintained, blood pressure is maintained. And once there is a failure, too much advanced, and the blood loss is much more, it goes to a state of class 3 and class 4, where in addition to the tachycardia, the blood pressure falls, tries to fall in class 3. It fails to have a compensatory mechanism in class 3 and class 4. Similarly, the pulse pressure is decreased starting from class 2. Just compensation is not able to fill up the pressure, pulse pressure. And capillary fill is delayed in class 2, class 3, and class 4. The respiratory rate is also altered. The more of tachypnea occurs as you prolong the class. And mental status or altered sensorium is only in class 3 and class 4. In class 2, is only mildly anxious, but in class 3 and class 4, she's a little bit confused and lethargic and frank altered sensorium as seen for that. So this is a very invaluable aid for the clinicians to find out, to approximate, to find out that the degree of blood loss, whether starts from 15% or more than 40%. And accordingly, you treat it either with the crystalloid or with the blood. Now, therefore, the treatment important is assessment of class. So you have to assess the class, and these are very simple clinical criteria. And once you assess it, resuscitative measures. The first and foremost is the replacement. Very important is the replacement of that loss. And you have to monitor each of the criteria. And either blood, if you are giving it, whether you give a blood component therapy, or if it's a severe hemorrhage, I think more than 40%, 50% or continuing bleeding, then the massive transfusion protocol has to be adopted for that. Now, one question about the pressure agents. In hemorrhagic shock, is there a role for pressure agents? Believe me, all the natural, it's a general practice that once the BP is low, you give a pressure agents. But this is not applicable for the hemorrhagic shock. The primary thing, a priority is to replace either with the crystalloids or with the blood. And subsequently, you can fill up, you can add with the pressure agents. But primarily, if you give a vasoconstrictor, a pressure agents, it will be more fatal. This will impair the kidney functions, and acute kidney injury can be consequently for that. And therefore, don't give a pressure agents first. Replace the blood, and then subsequently, after replacement, then if we find that still the blood pressure and hypotension is there, pressure agents has to be. This is the fundamental rule I can say. But believe me, once the hypotension is there, people are starting all the pressure agents, starting from the noradrenaline to the other pressure, vasopressin and other things for that. Now, most important, along with the resuscitative measures, arrest of hemorrhage is important for that. Not that if there is a bleeding, if you go on just a resuscitative measures, ignore it and find out and ask for the blood transfusion, ask for the bringing out the blood and replacement with the blood, and then following the surgery, I think it's not a wise decision. Suppose there is an ectopic pregnancy, bleeding is continuing, or there is a bleeding, particularly after delivery, there is a bleeding. You may ask for requisition of multiple units of blood, but at least same time you start therapy. You find out where is the cause of hemorrhage and arrest the hemorrhage. This should be very, very important part which should be understood for that. And therefore, don't wait for blood and start therapy for that. So arrest of hemorrhage is a simultaneous thing along with the resuscitation. Treatment of coagulopathy. Bleeding begets bleeding, and there are a lot of cases where the coagulopathy is also related to the bleeding, and therefore appropriate the fractions of the coagulation pattern or the coagulation factors can be transfused with that. One of the important, when we are in a periphery, when the approach, from the PHCs, one has to transfer it to the higher center, the secondary center, the transport is important. And during the phase of transport also, it's your role that you take a lot of precautions and transport that. And the brightest example is when I remember way back in 2011, I gave emphasis on this particular aspect of non-pneumatic anti-shock garment. Non-pneumatic anti-shock garment was very popular during that time, and still I say that this is a very invaluable tool to save life. This is a very important gift from the military technology, from the defense, from the trauma medicine to the medical fields, and particularly to the gynecologist for that. And I have a lot of personal experience on this non-pneumatic anti-shock garment in the labor room. And at that time, I distributed free to many of the medical colleges where they've experimented, and they have a full proof evidence. I have seen personally that when the pulse is not palpable, when the IV drip is not given, not able to give it, you give an anti-shock garment and immediately you find the pulse. And the circulation, the rearrangement of the blood circulation occurs from the less vital to the more vital organs like your brain, heart, and so that the life can be saved for that. So this is definitely a place, NSG is definitely a place, particularly in obstetrics and gynecology. And this can be used as a transport methodology for that. And therefore, in the subsequent, in the peripheral part also, if with the NSG, the transport is there, the life is saved, that the devastating situation will not occur on the road. Distributive shock. Distributive shock, the brightest example is septic shock, neurogenic shock, anaphylaxis, and serious adverse drug reactions. In this particular case, when there's a distribution of the intravascular as well as the extravascular compartment, the difference is that once there is a hemorrhagic shock, the systemic vascular resistance increases, and that is a compensatory mechanism for the heart to pump more to increase the cardiac output, and therefore there is a tachycardia for that. Whereas in a case of distributive shock, the contrast occurs, systemic vascular resistance falls. There are agents either because of the toxins, the peripheral circulatory vessels lose the resistance. Once the systemic vascular resistance is lost, I think the cardiac failure is supplemental to it. And that is the basic difference between distributive shock and the hemorrhagic shock for that. So here, the vascular resistance is decreased, whereas in the hemorrhagic shock, there is a vasoconstriction. Hemorrhagic shock as a hemostasis, physiological homeostasis mechanism, the vascular resistance will increase for that. Whereas in a neurogenic shock, what happens? In the neurogenic shock again, the vascular resistance will fall, but here instead of tachycardia, there could be a direct effect on the heart. A bradycardia could be there for that. So neurogenic shock, a tachycardia, instead of tachycardia, there will be a bradycardia in contrast to septic shock, but the peripheral resistance will decrease for that. Same thing happens with the anaphylaxis. Anaphylaxis is a very sudden event, and suddenly it affects the central failure and the cardiac pump failure, as well as the constriction of the respiratory system. And therefore, this is anaphylaxis, drug anaphylaxis. We see the various manifestations of anaphylaxis. And of course, the severe adverse reactions of the drugs, different drugs. I will just show some of my own experiences for that. So the septic shock, the identifying, when you find a septic shock and diagnosed, there are three methods which is there. As far as the management is concerned, first important is identifying the source and control of the source by either a medical or surgical methods. Second, start appropriate antibiotic therapy, empirical or definitive. It's a wise to say that according to the culture and sensitivity, you have to go, but it has been seen by scientific study that 1 hour delay of starting antibiotic will give rise to 16% more incidence of mortality. And therefore, you start the empirical broad spectrum antibiotic till the definitive comes. You send it for the culture and then transfer. So the main is antibiotics, broad spectrum antibiotics, identifying the source and control. Third is restoration of cellular perfusion. As I have already told, the septic shock, there is a need for vasopressors because the vasodilation there occurs. The systemic vascular resistance is decreased. So there is a need for vasopressors. And secondary to the vascular resistance, decreased vascular resistance, the cardiac failure occurs because the contractility is affected for that. And therefore, there is a need for inotropic agents. So vasopressors, the noradrenaline is the first drug of choice. You can give it for that. Vasopressin, you can give it for that. On then you can give the inotropes like the dobutamine is the better inotrope for that. So these combinations of all this restoration of cellular perfusion by giving an inotropes and giving a vasopressors, correct vasopressors, and with or without the steroids can help in a better way for that. And there are the number of vasopressors are there. You have to select it, whether the norepinephrine, vasopressin, or some of the other agents related to the vasopressin effect, like the vasopressin, the steroids, which because many of the cases adrenal insufficiency occurs and steroid can help as a supportive methods for that. But whatever it may be, according to the choice of these particular agents, this is the third important part in septic shock, which you cannot forget. Anaphylactic shock, as I have already told, apart from the circulatory disturbance, there is some disturbance in the airway, and therefore the oxygen support is necessary for that. And the adrenaline is the only life-saving drug which helps in anaphylactic shock. All general principles that one should feel when the anaphylactic shock occurs. There is a tachycardia 140, 150. And if you give an adrenaline for that and directly IV adrenaline, it is absolutely proves contradictory. But this acts miraculously. As we give an adrenaline, if the tachycardia 150 falls down to 140, 130, 120, then normalize for that. And that is typical of anaphylactic shock. Neurogenic shock again. In a neurogenic shock, what happens? The neurogenic shock, instead of a tachycardia, the bradycardia occurs. And the systemic vascular resistance also falls, and the vasopressors have a great role for that. And in addition, the steroids, the oxygen support, and another thing about the perioperative period, pain relief. In addition to all these, you have to look for the pain relief. That is again an aggravating factor for the neurogenic shock, and that one should not ignore in perioperative period. Cardiogenic shock, the examples are cardiomyopathy, arrhythmia, valvular failure, MI, and drug-induced. The prevention is very important. In all perioperative conditions in gynecology and obstetrics, we always do a preoperative evaluation and preoperative cardiac status evaluation. Invariably, we do it. But what is the method? Either by clinical methods or by at least by ECG. The cases are all good. If you take a clinical history, for majority of the cases, it is good. But if there is a risk, at-risk cases of a cardiac, a known diabetic, a known chronic hypertensive, or a history of some anginal symptoms, I think a detailed evaluation has to be done. At least do a echocardiography. Do an echocardiography, or if possible, do a CT angio. I think these will eliminate and prevent some of the dangerous consequences following surgery for that. And there are cases where undiagnosed and during the case is absolutely normal case, the perioperative cardiac manifestations can occur and arrhythmia can occur because of the anesthetic agents used, or during the time of surgery related to the anesthesia, some of the cardiac problem can occur. Or coincidentally, myocardial infarction, acute myocardial infarction has been noticed also in perioperative, in postoperative period, and the surgeon is unnecessarily blamed for that. So this could be a reason, a spectrum of event in a cardiogenic shock, and a prevention and treatment both are necessary. And here you have to take help of a cardiologist. So therefore, these are the cases you call help from the specialty, the other faculties, and then start the treatment if at all there is any problem for that. Now, obstructive shock. Obstructive shock, massive pulmonary embolism. This is one example of obstructive shock. Amniotic fluid embolism, which we say in obstetrics, we say if you do not find any cause and shock, obstetric shock, idiopathic, it's an amniotic fluid embolism. How to diagnose? It's a great helm of affairs to diagnose amniotic fluid embolism. To find out on post-mortem, you find out the debris, amniotic fluid in the lungs, and then confirm it and all that. It's a hell of a job for that. But before that, to diagnose amniotic fluid embolism, basically it reveals some of the clinical criteria. You suspect that and start treatment in that. But acute pulmonary embolism is a massive pulmonary embolism. The patient doesn't get more of time for that. Immediately severe, and all of a sudden, immediately they find that the breathlessness and systemic manifestations, hypotension, the tachycardia, all features up there, and lungs are collapsed. And these are the cases. An early diagnosis is necessary for that. And cardiac tamponade, tension pneumothorax. I have seen few of my cases. At least I have seen one case of tension pneumothorax in perioperative period for that. I will share my experience on that. And the treatment, particularly for the pulmonary embolism, heparin therapy is the ideal treatment for pulmonary embolism. But believe me, heparin therapy, particularly for massive pulmonary embolism, it's not a treatment, because you have to immediately relieve the obstructions, and therefore immediately a surgical intervention of I think nowadays the vascular surgeons or the vascular interventional radiologists are doing a thrombectomy procedure for that. So interventional procedure of thrombectomy or the thrombolysin therapy, the local thrombolysin therapy, is much more better than systemic thrombolysin therapy, because there is a risk of bleeding in a perioperative or surgical patient, that they cannot give a systemic thrombolytic therapy, but the local thrombolytic therapy or a surgical thrombectomy can be a better option to save the life in a case of massive pulmonary embolism. But in a case where it's not a massive pulmonary embolism, you have done a surgery, and on second, third day, you find the features of breathlessness, you find the rails and bronchi over the lungs and features of pulmonary embolism for that. You diagnose that this is a case of pulmonary embolism with or without evidence of the calf tenderness and all that. In that particular case, you start therapy with the heparin or low molecular weight heparin for that. Much ahead, if you suspect some of the cases, you can give a preventive dose. And in all pelvic surgery, in post-cesarean, I think the weight is very, very important. My practice is a weight beyond 90 kgs, or a multiple, a difficult extensive surgery in the pelvis, or a multiple surgery. You just give a perioperative thrombolytic, I think, heparin therapy and low molecular weight heparin for a couple of days, like you started during the time of surgery, and continue it up to about 72 hours is enough to prevent this pulmonary embolism for that. So prevention is important. And if at all is the mild symptoms, you start the therapy with the thrombolysins. If it is a massive pulmonary embolism, you have to go for the more drastic, experienced help of the interventional radiologist and do a thrombectomy for that. If there is a either the pericardial effusion or a cardiac tamponade, I think the pericardiocentesis is going to save the life. I can share one of my example, one of my experience. One patient, postmenopausal, 60 years, and a very VIP, mother of a senior bureaucrat, was being consulted by me that she has been admitted in ICU in the Apollo hospital. She has bleeding PV, and she is giving history of a cardiac stenting operation about 6 weeks before, 1.5 months before stenting. And because of the bleeding, they consulted me. I went there and saw that the patient was intubated in ICU, and she was given a broad spectrum antibiotic, thinking that there could be a sepsis, focus of sepsis involved in that. And the cardiologist has continually ruling out that there is no abnormality, excepting there is a pericardial effusion, small pericardial effusion. And I discussed with them that yes, they say that no, this amount of pericardial effusion is not going to affect this manifestations, is not going to that. And you see your condition. I said that gynecological condition, there is no gynecological conditions because there is a post-menstrual. The first need of the hour is saving the life of this particular patient rather than managing the post-menopausal bleeding. And I insisted, consulted the cardiologist, 2-3 cardiologists, I insisted that you do a tapping, pericardiosynthesis. Let us see for that. And then they didn't agree, but they found some slight improvement in the general condition after 24 hours of intubation. Then they extubated. Once they extubated, again the symptoms recurred, and again they intubated it. And then they could realize that yes, there is a place for the pericardiosynthesis. And I insisted that you do a tap and that. And they removed about 150 cc of pericardial fluid, and immediately the patient recovered and discharged from the hospital after 48 hours and survived up to about 4 years after that. So this is the brightest example where a right decision at the right moment is important for that. So pericardiosynthesis is important for cardiac temperament. Tension pneumothorax. Again, I will share one of my experience in that tension pneumothorax in my situation analysis, where a simple chest tube placement is a miraculous method of saving life for that. So therefore, the perioperative shock in obstetrics and gynecology, the principles and practice are identifying the spectrum and division into the 4 different varieties and categories, finding the cause and appropriate treatment by medical as well as surgical methods is important. Prevention and early intervention is important, particularly for intraoperative measures. During the time of surgery, in the OT itself, you have to find out, you have to be very vigilant on the preventive aspect as well as early intervention. And there is a need of obstetric and gynec ICU. So intensive care is important. And therefore, I always say that critical care medicine, some fundamental principles and practice has to be imbibed and infused into the gynecologist, general gynecologist for that. It is not only the prerogative of the intensivist or the prerogative of the critical care medicine specialist. It is our role which is going to solve a great problem in eliminating, saving life. And ancillary help and multidisciplinary approach. I fully agree that ancillary help and multidisciplinary approach, like cardiologist help, like the critical care specialist help, is absolutely necessary at a particular stage for that. And for that, we have to upgrade ourselves. And therefore, I feel that there is a need of subspecialty training in critical care medicine in obstetrics and gynecology. One should know something about the critical care medicine, and therefore that should be included under the syllabus in postgraduate. I thought when I was an HOD, I distributed a 3 years postgraduate course. I divided that 6 months they should go beyond gynecology department and serving the different places. 1 month training in critical care unit ICU, I posted. 1 month in the gynecological oncology. Then 15 days in the GI surgery department. 15 days in the urology department. 7 days in the plastic surgery department. And 7 days in the anatomy department, applied anatomy. So I think this is absolutely essential. As a teaching module, from the beginning of the teaching career, one should be exposed to all these varieties. It's not the prerogative of only the critical care specialist. You should know a little bit the fundamental thing. And then if beyond that, for you need a help, you can get help from that. So the focused areas, again, is the pre-op evaluation. You preventive, this is important. At risk, identifying at-risk populations or at-risk patients. Then intraoperative events. There are various intraoperative events. So bleeding, hemorrhage, tackling hemorrhage during surgery. I have a different episode. Last episode, in one of the episodes, I have focused on the hemorrhage during surgery. So how to reduce it, and the technique for arresting hemorrhage at earliest is important, so that we have to keep it in the compensated phase. We do not go for a decompensated phase and do drastic events and cannot save the patient for that. So therefore, intraoperative events is important. And of course, postoperative monitoring and postoperative management, as and when required, you should know for that. And intraoperative complications, what are the intraoperative complications? Anesthesia related, you must know something about that. Drug related, you must something about that. And of course, surgery related, you must have a thought on that. Anesthesia related, hypoxia, hypotension, total spinal, aspiration, incomplete recovery or delayed recovery, awareness and pain factor. Drug related, what are the anaphylaxis? What are the specific drugs which causes anaphylaxis? Lignocaine and bupivacaine toxicity, adrenaline, and we are using the vasopressin. Adrenal vasopressin we are using as a hemostatic measures while doing a surgery, and therefore the adverse effects and how to tackle those has to be known by the gynecologist. And of course, surgery related hemorrhage, injury to adjacent organs like a bladder, rectus sigmoid, intestine, stomach, all these has to be known for that, because unrecognized injury to the gut in the post-operative phase, that can give rise to a septic shock, and we got a mortality, fatality for that. So the post-op parameters of significance need to be addressed scientifically and analytically. It's not a very simple thing, a clinical methods of it, tachycardia, pulse rate, gives some informative idea about the general condition. Blood pressure, dyspnea, saturation, pyrexia, urine output, and the color. This is important, urine output. If the patient is urine output is very good, I'm very happy that the urine output is good. Even if the BP is 90, I'm all happy for that. I'm not bothered if the BP is 80 or 90. Abdominal distension, bowel movement, altered sensor, these are all important. Abdominal distension. And remember, in a minimal invasive surgery, I've already told the dictum is that in a minimal invasive surgery, the day by day, hour by hour, and minute by minute, patient should improve. Following surgery, if the patient is not improving day by day, hour by hour, or minute by minute, you think that there is some problem. And don't take it lightly. Don't complacent attitude. Don't have a complacent attitude. And just surgical interference, early interference will save life for that. And pain, headache, vomiting, loose motion, paresis, all these are post-op parameters of significance, which must be analytically and scientifically analyzed for that. Now, the second part important is sharing my experiences. As I always in all my episodes, I have a brief knowledge of what is the concept on this perioperative shock and the various types and the pathophysiology and the management for that. And this is how then the second important component, what we see day and night, and what is my real experiences over that, I will just ventilate within this second part. The obstetric scenario. These are some of the obstetric scenarios. Situation 1. Second gravida para 1, post-seizure and pregnancy, 10 weeks gestation, and the bleeding for 4 days. And she came with the heavy bleeding for 4 hours. On examination, she is extremely, the moderate degree of pallor, pulse is feeble, BP is 70 over 840 millimeter mercury, cold clammy skin, tachypneic, active bleeding PB continue. Here, I think it's a very simple. One should say that yes, it's an incomplete abortion. What is there in it? And one should not be complacent in this particular patient. She has gone up to stage of bleeding to such an extent, alarming bleeding, that she has presented with peripheral circulatory failure. And don't take it lightly. And time is also important. You cannot wait because the bleeding is continuing. How to proceed? The resuscitative measures and arrest of bleeding simultaneously should proceed here. Resuscitative measures, IV fluids, requisition of blood, oxygen support, and ecbolics has to be given on one end, and arrest of bleeding should be there. Emergency evacuation. Emergency evacuation saves life. If it is a small, even without anesthesia also, in your own peripheral setup also, don't ignore it. There's an active bleeding in a case of post-abortal bleeding or incomplete abortion, try to evacuate. Emergency evacuation has to be done. And if necessary, I have seen cases where after emergency evacuation also the bleeding continuing and all that. That's in order to save the life, hysterectomy as a life-saving procedure, you have to meditate for that. And to save the life, this can be done at the earliest procedure for that. But primarily, you evacuate, majority of the cases, the bleeding will be controlled. And the message is, alarming bleeding due to abortion could be fatal. Emergency evacuation along with the resuscitative measures saves life. And very common nowadays very common. And when their medical methods are abused, they're going off the counter, in the medicine pharmacy, they bring the medicines, the misoprostol are very well easily available, they take their self-medication, and then in the dead of night, they came with bleeding, and the doctor says that no, in the morning I will do it. By the time morning is there, the bleeding is certain extent that the patient's condition becomes very, very fatal. And therefore, no complacency in this particular situation. Even if it's an incomplete abortion, it has taken a lot of toll, death toll. And life is saved by simple procedure of active interference immediately with you. This is a situation too, way back about, I remember this is about 20 years back when I was in the medical college. This unmarried girl of 22, a very educated girl, was admitted to the hospital with features of shock. And history of induced abortion 10 days back. And she's an educated, but history of induced abortion by the quacks. Looks toxic, feeble pulse, BP not recordable, tachypneic, abdomen distension, double pulse, disoriented, hemoglobin was 6 gram percent, TLC count was 30,000, neutrophil 90%, sonography moderate, fluid in peritoneal cavity. There is a collection in the peritoneal cavity. Uterus was enlarged with mixed echogenic area of 6 centimeters in the cavity. She was admitted to ICU. IV fluids, meropenem, steroid, blood transfusion, oxygen support, nasogastric aspiration was being done. But at the same time, I decided to do immediate surgical exploration along with the resuscitative measures. Plan for surgical exploration. I did the laparotomy. I find a plenty of purulent fluid in the peritoneal cavity, the pus, full with pus. Gut was distended. Exploration of the gut was done. There was no gut injury could be found for that. But the frank pus was there. There is extensive adhesions of the intestines. And I explored everything. I didn't find a nick in the intestines for that. But the uterus was enlarged and it was a gangrenous. It's absolutely black. And I know that it's an unmarried girl. And there is a necrotic uterus, necrotic tissues inside the uterus, and the uterus is gangrenous. I decided for hysterectomy and abdominal drain given. And after that, she's an uneventful recovery, discharged on 12th post-op day. The classical principles of identifying the source of infection and source control is number 1. Antibiotics broad spectrum is number 2. I think this is very, very important for septic abortions. And all supportive measures are the resuscitative measures are number 3. These has to be gone simultaneously, not that one after another for that. And she was discharged on 12th post-op day. And I was very happy that this girl, before the discharge, I counseled this girl. She was very intelligent, but she admitted that she has done a mistake. And she told that, doctor, this is a turning point for me. I will contribute to the society henceforward. I will not marry, but I will contribute to the society. And now I learned that she is a very promising journalist in Delhi and doing a lot of social work on that and dedicated to the society. So therefore the message, unsafe abortion, though uncommon nowadays, but may present with severe sepsis. Supportive management, the broad spectrum antibiotics and tackling the source of sepsis is the key in saving life. And don't forget, early surgical intervention and tackling the source is of prime importance for that. So there are gone are the days. We are happy that we are not finding that incidence of septic abortions have drastically come down. And therefore, in our student career or in our early career of our profession, we are seeing every day in the 1 or 2 septic abortions cases come. And usually the recommendation at that time was a conservative management, antibiotic and all that. But I think the change in concept of early surgical intervention has a new light on saving lives for that. And therefore, I insist that early surgical intervention and tackling the source along with the antibiotic is the prime importance. Second Gavida Para 1 with sonographic evidence of missed abortion at 10th week of gestation with bleeding PV. She came with bleeding PV, and therefore I planned for evacuation under general short GA, total intravenous anesthesia. The pentothal or the propofol has been given. More commonly propofol the anesthetists are giving, and the anesthetist gave a propofol and evacuation was completed. Then the delayed recovery was there. I didn't find that unlike immediately the patient comes and then go to the home, the delayed recovery, hypotension, tachycardia with features of pulmonary edema, then put on ventilator support. Anesthetist put on ventilator support. All supportive measures has been given, but didn't improve after 2 hours. So the cardiology consultation was done, and the cardiologist saw and find that this is a case of tight mitral stenosis. The tight mitral stenosis, MS, mitral stenosis less than 1 centimeter diameter, and therefore these are decided for emergency balloon valvotomy. And immediately the emergency balloon valvotomy was done, and she was settled after 6 hours and discharged after 48 hours for that. So this is a situation where the life is saved because of emergency balloon valvotomy. But the mistake is that we have not diagnosed it earlier. So undiagnosed cardiac disease with pregnancy is not uncommon. And therefore, from that day onwards, I recommend all my anesthetists and all me also during the time of examination in OPD also, I put a stetho on the chest to find out. I'm not a cardiologist to find out a very small lesion, but at least tight mitral I can diagnose for that. So I request the anesthetist that don't take it lightly. That is a smaller operation, is a minor surgery, but put it the stetho for that. This undiagnosed cardiac. And if there is a suspicion, I think you refer to the cardiologist. And what happens? They are absolutely normal. But once there is an anesthetic procedure is there, usually it aggravates. Tight mitral stenosis, they aggravate. And they not recover unless you do a valvotomy for that. So that place of emergency valvotomy reverses the physiological events and saves the life. Diagnosis and appropriate management of cardiogenic shock in consultation with the cardiologist is absolutely vital for that. That I have learned from this particular case. Elderly primary gravida, 35 years with breech presentation, underwent LACS, developed hypotension. And the surgeon did the cesarean section. I was called after 6 hours that the patient is having shock. When I went there, I found that hypotension, tachycardia, and possible causes excluded. Features of shock persisted 4 hours after surgery. And syntocinon infusion discontinued. Significant improvement of features of shock, uneventful postoperative. This is really a case which I cannot forget. This is a case where she was a doctor, and now she's a professor in one of the discipline. She came, LSS was done, and immediately after delivery of the baby, hypotension, tachycardia after delivery of the baby happened. And that persisted 4 hours after surgery. Our anesthetist told that what are the drugs that has been given after the delivery of the baby, and therefore the only drug given was an oxytocin, syntocinon. And he told that yes, I will not give any drugs henceforward and find out what is the cause of this. This I strongly suspect that this could be an anaphylactic, drug reactions for that. And therefore only one drug has been given. The anesthetic are very sure that they are not given any sedative, they have not given any other anesthetic medication for that. And he told that I will omit the syntocinon, discontinue the syntocinon. The syntocinon infusion was discontinued, and immediately after discontinuation of the syntocinon, there is a significant improvement of features of shock and uneventful postoperative period. And I learned that this is the first case in my life was anaphylaxis to oxytocin. Could be there. They've been reported that yes, we have seen anaphylaxis to antibiotics, anaphylaxis to analgesics, anaphylaxis to even iron injection, but anaphylaxis to oxytocin I have known. I must give a credit to the anesthetist that yes, you have rightly pointed out, as soon as you found a drastic peripheral circulatory failure, immediately after injection of that particular thing, you thought that this could be a drug of relevance for that. So therefore, drug anaphylaxis is not uncommon. Commonly reported agents are antibiotics and analgesics, but individual sensitivity to various medications is variable, and identifying the agent is of prime importance for that. So this is the brightest example of the anaphylactic or a distributive shock. This is not a peculiar characteristics of a distributive shock, but the suspicions is there, and we are not used to that. And therefore, this is one lesson I must convey to all my obstetricians that I have seen one case for that. And the second pregnancy, when she came to me again in the second cesarean, she repeatedly telling that don't give me oxytocin and oxytocin and oxytocin for that. I know that this is something relevant, and the second pregnancy went on very smooth, and postoperative period was very uneventful. Situation 5, 28 years conceived following infertility. Diagnostic therapeutic hysterolaparoscopy was done. Hysteroscopic cannulation was done. Overdue was 14 days with spotting PV. Now UPT was positive. She was conceived following hysteroscopic cannulation and sonography revealed empty uterine cavity. Endometrium thickness is 8 millimeter. Gestational sac was found in the left adnexal region, but no fetal node. And serum beta HCG was in the range of 1500. Repeat beta HCG after 48 hours is not a significant improvement, 1600 ml milli-international unit. And again, sonography, repeat sonography, cavity was empty, gestational sac visualized left adnexal. Again, no fetal pole, no fetal node, no cardiac activity, and therefore planned for medical management. An injection methotrexate was given, 50 milligram. I am given. He refused for hospitalization. I advised for hospitalization. She refused. Counseling done for immediate hospitalization in warning symptomatology and advised for review beta HCG and sonography after 1 week. Presented after 3 days with syncopal attack and acute pain abdomen. And on examination, I find pulse rate was 140 per minute, BP 70/40, abdominal distension, free fluid in the blood in the peritoneal cavity, and therefore it was diagnosed earlier, planned for immediate surgery. Sonography was a massive hemoperitoneum for that. And this was the picture on this laparoscopy, putting on laparoscopy. And even if this hypotension, peripheral circulatory failure is there, I decided to do under the GA, and that too with laparoscopy procedure. Gone are the areas where earlier we were telling that in hemodynamically unstable patient, laparoscopy is contraindicated, but yesterday's contraindications are today's indication. If she's fit for anesthesia, she's fit for surgery for that. If she's fit for general anesthesia, she's fit for laparotomy as well as for laparoscopy for that. So here, the main thing is that either you can give her auto transfusion, multiple transfusion arrangement of that, simultaneous is there, but don't wait for blood transfusion and then do a surgery. It should be concomitant procedure. And the main thing is that you identify the source of bleeding and don't try to clean the peritoneal lavage. Complete peritoneal lavage is not necessary. You identify first, arrest the bleeding, do a salpingectomy, and then this is the site of bleeding is there. Do a salpingectomy, immediately arrest the bleeding, and then coolly you can do that peritoneal lavage. And once you do a salpingectomy, you immediately find that the blood pressure will rise and the tachycardia will gradually be resorted to a normal thing for that. But this is important that you don't prolong the procedure. You immediately arrest the bleeding by doing a salpingectomy. And the same procedure has been done with the salpingectomy immediately, and then subsequently good peritoneal lavage and removal of the blood and blood clots can be done for that. So this is the only surgical trick I can give you, but suspicion of bleeding and identification of this and immediate tackling of the bleeding is important to save the life of this particular patient. And then immediately the shock will revive. And once the arrest of the bleeding is there, the supportive treatment of either crystalloids or blood or can save the life. And once the bleeding is stopped for that. So this is one of the very important procedures in the shock in the perioperative period for that. So need for immediate surgery is an emergency. Arrangement of blood is auto-transfusion is simultaneous. Pre-plasma expander or fluids are important. Arresting bleeding is the primary surgical step. Again, I am emphasizing this. Reducing intraoperative timing of surgery. Don't prolong it as quickly as possible. So you must be steady. You must be fast. It's not slow and steady. It's a fast and steady. And the cool temperament, steady procedure, confidence is the key to success for that. The primary gravida 38 weeks in labor, planned for emergency cesarean section due to non-progress. Delivery of the baby done with classical gymnastics. At that time, I'm telling about 25 years before. Delivery of the baby done with classical gymnastics and fundal pressure, extension of the uterine on left side, involving the uterine extension of the lower uterine segment on right angle, hypotension, tachycardia, tachypnea, and the patient was in shock in the intraoperative period. Now you have to be very, very vigilant. You have not done, I think two things are important. Why it has happened, the prevention, how to prevent it, and how to manage. This is all important for that. And therefore, in this particular case, immediately there is a case of traumatic PPH and it's a iatrogenic PPH. So supplementation and transfusion of 2 units of blood transfusion is given, but the good repair immediately, arrest of bleeding at that particular area on the lateral angle and the uterine has to be done separately, not with the same apex, with the muscle, with the vessel. You don't have a time. So identify the bleeding vessels, tie it separately, and then start. And after arrest of the bleeding, then post-operative, immediately you have to monitor with the fluids, with the blood transfusion and all necessary measures, and absorb for the ICU for 24 hours settle. So the things comes in me, how to prevent and how to manage. These are the two things. So prevention is there. You have a wrong delivery of the baby, and you have to find out the right technique of delivery of the baby is essential. About 25 years back, this is my personal experience, I thought I will never deliver the same gymnastic method of delivery by cesarean. Then I switched off to forceps. Forceps, again, I find that the right application of the forceps in a cephalic and a pelvic curve and is not possible. And even with the Vactis also, there is a lot of problem of even pond fracture of the fetal bone skull. And therefore, vacuum. When the vacuum came, I think the elastic vacuum came. I think this is very important that I applied that. And therefore, the vacuum I applied and prevented for that. And for the treatment, the bleeder can be tackled. You identify the bleeder and take a separate bite from the bleeder in the angle. Don't include everything and blindly you take bite, which people do. I recommend that. You just identify where is the source of bleeding in the below and above. You just have a bite, arrest the bleeding, catch hold of the angle, and then start closing the uterus. That's a treatment part. But vacuum is important, and this is see from that time onwards. For last 25 years, I always advise that yes, this method of delivery of the baby is always with the vacuum, provided the head is there. Even if the low head, high head, or mid head, whatever may be, if the head is there, you must deliver it so that the gymnastics is not there and lateral extension will not be there for that. And therefore, since all the time, I personally do and advise all my students to follow that procedure for the elastic vacuum for that. So this is how you just apply the vacuum. I think this is the procedure of application of the vacuum, elastic vacuum, half to the scalp and half to the uterine wound. And with the index finger, you just strip it and find out the hole. So no need of again a fundal pressure and gymnastics in the OT for that. And this will prevent not only the operative gymnastics, but they prevent the lateral extension of injury and involvement of the uterine artery for that. So this is important, which I wanted to show. Again, in cesarean section, this is an example where Mrs. Z G3P2 placenta previa. This is a case of placenta previa with previous cesarean section presented with transverse lie at 36 weeks. And therefore, decision is LSCS, previous cesarean with the placenta previa, transverse lie, and LSCS was done. Male baby of 2.4 kg delivered with the difficulty, with fracture left femur of the baby, not of the gynecologist, and lateral extension of uterine incision with broad ligament hematoma, uterine atony, PPH, shock, and patient resuscitated and said. This is an example where intraoperative shock was there and you created that. It is definitely because of faulty delivery of this, how to prevent and how to manage. So the pre-op planning is important. You must keep your mindset ready that this is a risk case where a previous cesarean with transverse lie, with placenta previa, all risks are there. And identifying the risk factors of post-cesarean, placenta previa, malpresentation. So PPH, both atonic and traumatic can be there. So ask for help. Senior consultant should be asked for that. And these are some preventive surgical steps in this particular case. Tackling vessels before incision. There could be vessels. You just tie it proximal and distal. U-shaped incision on uterus so that extension will not be there on the lateral aspect. Gentle delivery of the baby. Prophylactic alcoholics, pack, press and pray. I always remember these three principles: pack, press and pray. Active management of third stage of labor. And nowadays, good hemostatic, good alcoholics are important. They are available. Now the carbitocin has changed the scenario. And earlier we were giving the oxytocin. Previously we were giving methergin. I have abandoned methergin long back. Then the oxytocin was being used as recommended by active management of third stage of labor by WHO. And then subsequently carbitocin. Carbitocin, I'm using it routinely so that the main advantage of carbitocin is that not only is very effective, but after delivery in the cesarean, in all next 3 to 4 drips, oxytocin is not desirable also. It's not required also. And the PPH is a very good aquabolics, and even 1 ampoule or 1 vial of this carbitocin is enough to control the bleeding, and intraoperative and postoperative is very, very good as far as the bleeding is concerned for that. But recognize active bleeders, tackle separately, optimum hemostatic closure and peripartum monitoring. So the message here, preventive surgical procedures is mandatory, adequate surgical skill to arrest bleeding as earliest, concomitant management of shock and anesthetic help saves life. So here you have to control the bleeding, you have to arrest the bleeding, and the anesthetist has to have a supportive management of shock, either with the replacement of adequate amount of crystalloids or with the blood or both, along with or without pressure agents for that. And peripartum monitoring in ICU is needed for that. Mrs. Y, 32 years, third gravida, para 2, L2, previous 2 CS with major degree of placenta previa. Third episode of bleeding at 35 weeks, breach, planned for emergency LSCS. Now you anticipate and counsel. Before that, it's a very important counsel that bleeding will be more. And they may, because the bleeding, the hemorrhagic shock will be more incidence, and arrangement of blood is a prior requirement for that. Need for hysterectomy. If at all the bleeding is continuing, we have to resort for hysterectomy. She is 32 and need for hysterectomy is a prime importance. You have to counsel it. And this particular case, suprapubic incision was given. Extensive adhesion of UV space with engorged veins. UV space opened. Severe bleeding from the space. Placental tissue engulfing the bladder wall. Lower segment muscle not identified. Foot of the baby grasped, entering through the placenta, and a preterm male baby of 2 kg delivered with optimum Apgar score. Placenta morbidly adherent to the lower uterine segment and bladder. Active bleeding from the lower uterine segment was there. So here, because of the torrential bleeding, you don't want to arrest the bleeding by just suturing and then leaving it such, and unnecessarily wasting the time. And therefore, decision for emergency hysterectomy was taken. It's better to do a hysterectomy to save the life, and then to wait, do a sequential devascularization, and then subsequently decide for hysterectomy by the time the cardiac arrest will be there. So total abdominal hysterectomy done, difficulty in dissection of bladder, excision of bladder, posterior bladder flap, along with the placental tissue done, bladder repaired in 2 layers, hemostasis maintained, indwelling catheter given, uneventful post-op recovery, indwelling catheter removed after 14 days. This is a case, the frank case, and the life is saved. There is an extensive adhesion of the bladder, and bladder was involved with that, and you find that there is a placenta increta, and this particular thing, you don't go for stepwise devascularization. Take immediate steps to arrest the bleeding and save the life of the patient. So this is the decision is important, and the dissection is both important, and then you can save the life of the patient. The whole placenta is completely embedded with the uterus as well as engulfing the urinary bladder for that. So in the lower part, you go for a complete total abdominal hysterectomy. No place for the electrocoagulation here. Always use a suture in this particular case, pregnant uterus, to do a, but the time is important. Again, steady and fast. Steady and fast, and along with that, the necessity measures will be done by the anesthetist, and you see the life is saved by this procedure for that. So don't hesitate to do the hysterectomy. In a case where there's a 35 years, she's a para 2, completed family, you must be second thought in a case of primary. But even if it's there in primary, saving a life is important for that. So anticipate possible problem and counseling. Decision for total hysterectomy, not stepwise devascularization. Steady but fast surgery with hemostasis. Watertight closure of bladder with indwelling catheter if the bladder is involved in that. Maintaining hemostasis all throughout the procedure. I think this is the tips and tricks in surgical procedure. A preventive surgery can save particularly a life. Third gravida, abortion 2 at 36 weeks. Previous 3 episodes of bleeding PV. Sonographic evidence of low-lying placenta with breech presentation. Planned for LSS. What should be the surgical approach? Again, you have to counsel it. And during the time of surgery, you can find as soon as you go and incise the lower uterine segment, there is a torrential bleeding from that, because the only thing is that If the placenta is posterior, the bleeding is less. If the placenta is anterior, it is horrible. The engorged veins are there and you have to go through the placenta for that. So you have to identify. And by the time you go through that, there is a torrential bleeding and lot of volume loss is there. The blood loss is there for that. So a very important procedure is that identify and rapidly, swiftly, you must complete the procedure of this cesarean section. And how to enter that? You have to go through the placenta or shearing with the placenta and finding a cleavage and then go through it. Here I went through the placenta and then I cut the placenta and membranes and then hold the baby foot, the breech, and then breech extraction is done. And immediately after that, you give an ecbolics like the carbutocin is very good for that, and give ecbolics. And after that, remove the placenta. And if it is adherent, then there is a problem. If it is not adherent, from the bed, there could be a bleeding. You can suture the bleeders from the placental blade and then complete the procedure. So this is how you do a preventive surgery to prevent the intraoperative shock from the hemorrhage which is encountered. For this is obvious that could be hemorrhage. You have to be cautious about it. You have to counsel to arrange a blood transfusion. But with this technique, I think if you do with that, provided the placenta is not having a morbid adhesions, it is not going to, the hysterectomy is not necessary, and you can fully jolly well do the cesarean section. But taking very special precaution on the hemostatic closure of the wound, and then in the bed also, you must put 1 or 2 sutures if there is an active bleeding for that. And along with the ecbolics, this thing can be tackled very well. And now the bleeding is completed, the bleeding is controlled, and then with the proper cleavage, I didn't find this morbid adhesion. And here, the whole thing can be done very well with a meticulous technique for that. And whatever little blood loss is there, that can be recovered. An early stage of shock, it must be a class 1 shock, which can be easily dealt with by crystalloids and all that. So hemostatic suture, proximal and distal in anterior low-lying placenta, deliver the baby through the placental tissue, or finding a cleavage and entering into membranes, timely ecbolics, hemostatic suture in the placental bed. These are the fundamental tips and tricks in surgery. You must do that. This is another case, primigravida gravida, elective CS for breech with PIH, uneventful surgery, transferred to ward after 4 hours, and then reported to have peripheral circulatory failure with respiratory distress, pulse rate 160 per minute, BP not recordable, patient is sweating. Now, what should be the workup? You must think what should be the cause for that. Think possible cause. It could be anesthesia related because long-acting regional anesthesia, anesthetic agents are being given, bupivacaine or sensorcaine, anesthesia related, or some drug related. Some of the drug has been given, postoperative analgesics, or some of the drugs in ward that has been given, which can cause an anaphylaxis, or surgery related. The most important surgery related is hemorrhage, internal hemorrhage. You find out these and think possible causes. And apart from it, non-obstetric cause, embolism. We rely to embolism, we don't find any cause, we say that it's amniotic fluid embolism. For the medical legal purpose, it's all right. But for technical reasons and for your own satisfaction and introspection, it is not satisfactory. Or sepsis. This early sepsis is very rare, particularly in obstetrics and gynecology. Within hours, sepsis doesn't ensure. It takes few days. It takes at least a 24 hours to 40 hours, unless it's a pre-existing chorioamnionitis. If there's a pre-existing chorioamnionitis, it takes hours. Otherwise, in urologic practice, it takes very rapidly. If within minutes, urologic practice that can occur. But in gynecology, provided there is a pre-existing infection, it takes at least 24 to 48 hours to sepsis to develop for that. And some of the cases could be undiagnosed entity for that. So such things can happen. Identify the cause and appropriate intervention is necessary. Need for obstetric ICU. This is a case where you should transfer this to an obstetric ICU and where multidisciplinary approach has to be adopted for that. And that can save the life. 30 years, primary infertility, 8 years, investigated elsewhere, presented with acute pain abdomen. 15 days ago, LMP. Fainting attack, Pilar triple plus. Pulse rate is 150, BP is 80 by 50. Abdomen is distended, tender, sonography, plenty of fluids, or Cori blood in peritoneal cavity. Plan for immediate surgery. And for laparoscopy. I thought that there could be an internal hemorrhage. Internal hemorrhage, commonly we believe that it is an ectopic pregnancy, and therefore just she gives history of LMP 15 days back. But in spite of all this, to be very sure, I sent a serum beta HCG and we're awaiting reports. I didn't wait for that because the patient is in shock. Immediately put on this laparoscopic approach, and I find plenty of fluid blood in the peritoneal cavity. Moderate to severe hemoperitoneum is there, and these are the cases where either ectopic or some of the cause attributable for severe intraperitoneal bleeding. Very rarely we get this particular case. This is a very atypical case. And when I was thinking that this could be ectopic, same symptoms like ectopic could be there, and the blood, massive hemoperitoneum giving rise to hemorrhagic shock. And just after peritoneal lavage, we find out that clearance of the blood from the peritoneal cavity, the organs could be visible. The upper surface of the uterus is now visible. Then good peritoneal lavage and the blood clots and blood are aspirated very quickly with that. And time is a very important factor because he's already in shock and on general anesthesia. And you must be very, very cautious about it and to find out the source of bleeding, where from the bleeding occurs. And commonly in a case of ectopic pregnancy, we find that yes, tubal pregnancy, the bleeding is there for that. Now the right tube and ovary is absolutely normal. There is no evidence of ectopic pregnancy on the right side. And on the left side, I will just find out after clearing the blood from the peritoneal and the POD, and the left ovary and tube is absolutely normal. So if the left ovary and tube is absolutely normal, the possibility of ectopic pregnancy or tubal pregnancy is ruled out. I confirmed it, and then I find out what is the source of bleeding. You can see this particular case, such extensive hemoperitoneum, there must be some continuous bleeding, and you must find out what is that. The next step we find out, and this is the posterior surface of the ovary, and we find that there is a bleeding here, and the posterior is small bleeding raw surface, and that is the corpus luteum. The corpus luteum hemorrhage manifesting in a massive hemoperitoneum, though rare, but it's possible. And your clinical suspicion of this particular are mainly on the clinical findings and features of shock. You must continue the supportive management of the volume replacement and blood replacement along with the arrest of the bleeding immediately. And the arrest of the bleeding here is very, very easy. By just putting a bipolar, you can arrest the bleeding and save the life of the patient. And you identify this. This is a case which is not very uncommon. I find a couple of cases like that, but the diagnosis is simulating the ectopic tubal rupture. And you find that these are the posterior surface of the ovary. You find an active bleeder here, and just with the help of the bipolar, just catch hold of, fix the ovary with the traumatic forceps, and it can be very well tackled with just coagulation with the bipolar. It's very simple. It's not a very big surgical acumen is necessary for that, but wise decision is important, appropriate decision in the appropriate time, and then immediately tackling that and arrest the bleeding and supportive treatment has given rise to a life for that. So these are the cases which are very atypical case, but presenting with the peripheral circulatory failure or shock in the perioperative period. That's why I wanted to share my experience on that, that you must have seen such similar incidents, and the same procedure you can do it and identify it by first a proper diagnosis, then with the procedure of laparoscopy and with the good anesthesis, with the supporting therapy, I think the whole procedure can be tackled. And that's all. This is the finish of the surgery. Just with the bipolar forceps, you just coagulate and arrest the bleeding, and that's the end of the procedure for that. So the massive hematoma, these are the, and beta CG report came after 4 hours. It is non-pregnant, less than 2. It coincides with our non-gestational bleeding from the ovary, from the corpus luteum. So the message is acute hemoperitoneum common in tubal rupture, but corpus luteum hemorrhage could be a differential diagnosis to be thought of. Diagnostic and therapeutic lab is the rational approach, and laparoscopy in hemodynamically unstable patient, not an absolute contraindication. And suction irrigation of blood and blood clots from the peritoneal cavity, including subdiaphragmatic region and paracolic gutters, and coagulation of bleeding points from the surface of the ovary serves the purpose for that. This again, 26 years priming gravida, underwent elective cesarean section for torn breech. And the surgeon was completely a different surgeon, very senior surgeon, and he did the surgery, and he has some work, left the city and for some other personal work. And after 12 hours, the hospital people informed me that you see this patient who has been operated 12 hours back, the features of peripheral circulatory failure, tachycardia, hypotension, tachypnea, pallor, cold, clammy skip, abdomen is distended, and call for help. And when I saw this particular patient, I was thinking that there is certain that there could be internal hemorrhage. And I advised for immediate exploration. And I ordered for requisition of 2 units of blood, and then laparotomy. Same laparotomy open up, and I was thinking that there could be some bleeding from the uterine wound. But surprisingly, there was a massive intraperitoneal collection of blood. I do a good toileting and find that the uterine suture was normal. And there was a small pulsatile twig from the edge of the peritoneum in intravesical space was detected. And the surgeon usually they don't close the peritoneum, they leave the peritoneum, the visceral as well as the parietal peritoneum, they leave it, and a single layer suture. That was the philosophy of that particular surgeon. I respect that, but when I find the small pulsatile twig, the uterine wound is absolutely normal, hemostatic, and I just coagulated, arrest the bleeding, abdomen closed in layers, and patient was on a ventful recovery. Then I thought, how a trivial thing has been ignored. Post-op intraperitoneal bleed not uncommon. Early recognition and surgical intervention saves life. And this you suspect and immediately open it. A typical case of bleeding from uterovascular space rather than uterine wound. Peritoneal closure versus non-closure acceptable. I am in favor of peritoneal closure. Whatever I will cut it, I will close it, both visceral and parietal peritoneum. From the beginning, that was my philosophy for that. And I'm always in favor of 2-layer closure, double layer closure from the beginning. And if at all the peritoneum is left, say for example in hysterectomy, or in case of where we do a laparoscopic hysterectomy, or in a case of the abdominal hysterectomy where we leave the peritoneum, or in a malignancy where you leave the peritoneum, be careful. Inspect the peritoneal edges. If there is a bleeding, you just coagulate for that. And that is the philosophy which I maintain and which I always tell. Gravida 3, para 2, 35 years, post-CS pregnancy at 18 weeks, attempted termination of pregnancy elsewhere, failed, presented with bleeding PV, sonography, single live fetus, 17.6 weeks, absent like a placenta low-lying, planned for hysterotomy. Hysterotomy, lower corpus, I open it, lower corpus and cervical ballooning with engorged veins, hysterotomy was done. There was a torrential bleeding from the edges. Placenta morbidly adherent to the cervix and bladder, as we see in the last case in the torn pregnancy. Here, it was an 18 weeks and it's a 35-year-old G3P2. Both are living. And patient developed immediately shock. When I opened it and torrential bleeding gave rise to shock, BP not recordable. Immediately, I decided for hysterectomy rather than any conjunctive procedures for that. I didn't plan for any devascularization, either interiliac ligation, which many people propose. I wanted to save the life and did a hysterectomy with excision of bladder wall done, bladder repaired, hemostasis maintained, along with necessary measures with volume replacement and multiple units of blood transfusion. Patient discharged with uneventful recovery. So the message is placental location, morbid adhesion, diagnostic accuracy by ultrasound. This is important, diagnostic accuracy. We should know that location of the placenta and the morbidly adjacent placenta should always be done in all pregnancy. Resort to hysterotomy rather than alternate method preferred. So hysterectomy is a method for that. And decision for hysterectomy in such cases saves life. So these are the cases where you must be very, very careful. The prime importance is the life of the patient. Third gravida abortion 2, TCR is done for subsepted uterus, septum resection, irregular ANC, presented with pain abdomen at 27th week. Uterus was 28 weeks tender, cervix long, os closed. Sonography revealed single live fetus, 27.2 weeks, estimated birth weight is 800 grams. Under observation with analgesic tocolytics, and after 24 hours, pain abdomen aggravated. And on examination, pulse rate was 140 per minute, BP was 80/60, poor abdomen distance and tenderness, uterine contour not fit. And immediately I diagnosed that this could be a silent rupture of the uterus. And immediate laparotomy was done. Massive hemoperitoneum, fresh stillborn male fetus and placenta in the peritoneal cavity, transverse rupture of uterus in the fundus with active bleeders, fetus and placenta are removed, peritoneal toileting done. And repair afferent in double layer with hemostasis was done. 2 units of blood transfused, uneventful post-op recovery. Patient was depressed, counseling done. Maternal life was saved, but motherhood shattered. Came for post-op checkup after 6 months, very much keen for a conception. Counseling is done for a surrogacy or adoption, and presented after 1 year with early pregnancy. Risk explained, insisted to continue pregnancy. Regular ANC with warning signs of possible rupture. At 32 weeks, elective cesarean, elective LSS was done. After betamethasone, glucocorticoids, preterm male baby of 1.8 kg delivered, kept in ICU for 5 days, an uneventful intraoperative and postoperative period, left the hospital with happiness for that. So risk of possible silent rupture following TCRS. Meticulous technique is required. There is evidence, there is a lot of literature showing a silent rupture. I have also seen silent rupture, either following TCRS or without that also. Many cases without any interventions also silent rupture has been seen. Diagnosis during pregnancy, sonography pointers should be there, warning signs to be conveyed, because the patient pain doesn't subside, and the warning signs you find the abdominal distension and aggravation of the pain is given a suspicion of some internal hemorrhage. More frequent ANC is required. Early recognition, immediate surgery may save life. Management of subsequent pregnancy is a big challenge. Early delivery, balancing the fetal maturity, will shape maternal as well as the fetal life. And this is a lesson to be learned for everybody, including me. This is 23 years, para 2, vaginal delivery. Full-term male baby was delivered, Apgar score 8/10, had severe PPH after delivery. Ecbolics was given and blood transfusions were arranged, and bleeding was continuing. Vitals was falling, and therefore the person concerned in charge of labor room decided for emergency hysterectomy. And emergency hysterectomy was done by the assistant professor. Hysterectomy was performed within no time, but bleeding continuing. Then she called me, sir, please see this case. I was operating on the other side, and please see this case. I put a speculum to see the source of bleeding. On putting a speculum, I find a tear, lateral vaginal wall tear with active bleeding. So I sutured it, but patient had a cardiac arrest and could not be revived. I think it's the wrong decision. Cesarean, the hysterectomy, emergency cesarean hysterectomy, believing that it is a case of atonic uterus, is a wrong decision. It's a traumatic PPH. Had in the initial phase, in the labor room itself, putting a speculum and finding out this tear and repaired it would have saved the life. Is it a bad luck of the lady or the bad hands of obstetricians? So therefore, the message is that all PPH are not supposed to be atonic. That's a presumption only. Brain should be active while hands are hyperactive. Guidelines has to be followed up, and introspection for future required. Don't blame the luck, blame yourself. 28 years, para 2, referred from PHC, delivered vaginally 2 hours before, with bleeding PV and features of peripheral circulatory failure, shock, and uterus not palpable. So I suspected inversion of uterus. With active bleeding, pulse rate was 140 per minute, BP was 50, not recordable, and resuscitation was done immediately with crystalloids and blood transfusion. And reposition was done by hydrostatic method. O'Sullivan was there. And therefore, I still believe practiced O'Sullivan by hydrostatic method, and it could be successful, discharged on eventful recovery. So active mismanagement of third stage is the commonest cause of inversion of uterus. I think that is a preventable entity for that. If at all there is an inversion during delivery, you immediately manually repose it immediately. And immediately, if you detect it and deposit, it's possible. If you give a gap, it is not possible. You have to resort to hydrostatic method, still successful in recent or subacute variety. So in a chronic variety, surgery is necessary, but in a subacute variety, hydrostatic methods. In acute, in presence of immediately you have done this manual reposition, it can be relieved for that. So concurrent management of shock is absolutely vital in addition to the procedure, and chronic inversion needs a surgical intervention. Primary gravida, vaginal delivery with medial lateral episiotomy, severe pain over perineum, and vagina after 6 hours of delivery with features of peripheral circulatory failure. On examination, apart from hypotension and tachycardia, swelling of episiotomy site, and there is a bulge in the left lateral wall. Diagnosis hematoma, commonly explained. Exploration was done immediately. Blood clots was removed and repaired with hemostasis. And what lessons we have learned? Vulval hematoma not uncommon following episiotomy. Meticulous technique to be adopted to prevent it during the time of the delivery. Meticulous technique has to be adopted right from the apex. You find out the other side of the vagina, you explore and find out if there is a tear and start, and with the strict hemostasis, you just repair it. And if at all there is hematoma, early diagnosis is required, because had she presented with 1 hour or 1.5 hours before, should have not presented with peripheral circulatory failure. From the time of pain, many people do have a pain after delivery. So without anything, you give analgesics for that. This is presume that this is normal. I don't think. If the patient is having complaint of pain abdomen, pain of the local area, just inspect. At the earliest, if you diagnose it, you can do it without anesthesia also, and without any features of shock, you can completely treat that individual. So don't delay it. So hemostatic closure is essential. Drain is optional. This is a primary gravida, vaginal delivery with forceps, episiotomy repaired, extension upwards. After 12 hours, patient developed pain abdomen and vagina on left side. Pulse rate 140 per minute, BP not recordable. Per abdomen, uterus contracted, 26 weeks, tender lump in left iliac fossa and suprapubic region. So immediately the clinical diagnosis was supralevator hematoma, and sonography confirmed clinical diagnosis. Immediately resuscitative measures for shock started. Decision for emergency laparotomy, broad ligament hematoma on left side, blood clots removed, active bleeders fulgurated, descending branch of uterine sutured, left internal iliac artery ligated, drain given, abdomen closed in layers, peripartum monitoring done, and she has a non-eventful recovery. So this case of traumatic PPH and shock and arrest of hemorrhage has to be done by immediate exploration. And supralevator hematoma seen in instrumental delivery. Meticulous suturing of vaginal lacerations with special reference to extension prevents such incidents, and it may be needed under anesthesia. This is needed under anesthesia. Early diagnosis and immediate surgical intervention by laparotomy is needed. If it is a infralevator, you can do it vaginally. If it is a supralevator hematoma, you have to explore it, and laparotomy has to be done. Identify the active bleeders and tackling the bleeding is necessary. If you find an active bleeder, you do it, explore, remove the clots and all that. But there is definitely a place for ipsilateral intrailiac artery ligation. And this is the case where I find intrailiac artery ligation ipsilateral has a promising and a rewarding result in this particular segment. One, there is a unilateral injury, unilateral affection of the uterine artery, and either because of the supralevator hematoma or because of the tear, rupture uterus on the lateral edge. This is the only case where the intrailiac ligation ipsilateral is of help for that. Para 2, spontaneous vaginal delivery at Torn presented after 4 days with breathlessness, abdominal distension, pyrexia, pulse rate 140 per minute, BP was 80/60, pallor plus, abdomen soft distension, ascites plus, uterus was 18 weeks, normal vaginal discharge. The normal delivery is 4 days back. CBC, RBC normal, RBS normal, on IV fluid, nasogastric aspiration, antibiotics, sonography is moderate ascites, uterus enlarged, cavity normal, no other intra-abdominal or pelvic pathology detected. Follow-up after 48 hours, increasing distension and ascites with dyspnea and features of peripheral circulatory failure. Now, patient developed shock. Surgical consultation was done and planned for exploration if condition doesn't improve. Paracentesis done, straw-colored fluid of 2 liters drained, review abdominopelvic sonography done, blood sent for serum amylase and lipase. I suspected that there could be a pancreatitis. Provisional diagnosis of acute pancreatitis was made. On conjunctive management with colloids and crystalloids with vasopressors, periodic lipase and amylase estimation and pancreatic imaging by MRI, and patient improved after 8 days, discharged on 10th post-op 10th day. And the message here, unusual association can occur, serum marker for diagnostic accuracy, lipase and amylase, diagnostic of acute pancreatitis, imaging modality, particularly the MRI, pancreas is increasing diagnostic accuracy than sonography. Conjunctive management is the key. Surgical exploration is unnecessary and rather aggravate the problem, and lessons to be learned for future. This is one case where acute pancreatitis, a medical condition, can affect particularly in peripartum, and that can give rise to the features of shock. Now, ladies and gentlemen, the next segment is a gynecological scenario. I finished the obstetric scenario. In gynecological scenario, what are the evidences of shock? But I find my own experiences, I will just share. 45 years, para 3, all cesarean section with mama uterus 20 weeks, planned for abdominal hysterectomy. After pre-anesthetic medication, my anesthetist found out that the monitor showing tachyarrhythmias and hypotension. Immediately, tachyarrhythmias and hypotension, just on pre-medication with Fortwin. Operation was postponed. I showed that no operation was postponed. Hydrocortisone was given, Xylocar was given, oxygen support was given, patient improved, rescheduled for surgery. And the same day, similar events observed in the next 2 cases after the pre-medication agent Fortwin, the same pre-medication agent Fortwin was given. And then I suspected, cancelled all that in the same day, and I draw that same batch of Fortwin, I ordered that, collected it and scrutiny for spurious drugs and sent it to the laboratory. And the drug laboratory report came after 2 weeks in favor of spurious medications. I think this is something which everybody should know and I should share with you. That spurious drugs causing shock and mortality is not uncommon. Remember, these are all not disclosed and unnecessarily the surgeon is being blamed. To identify becomes difficult on the part of the surgeon, but serious adverse reactions of drugs has become a concern for clinicians. We have seen the anaphylactic reactions, but the spurious drugs, I think in a batch in some of the hospitals, the newspapers say, the news says that yes, in one day, 4 or 5 deaths occur consecutively. I think these are the cases where some spurious drugs or fluids, IV fluids or spurious drugs are the causes for that, and identify that. And that's why this as causing the shock is also seen in this perioperative practice in obstetrics and gynecology, and that's why I wanted to give a message to that. This again, a very old case, about 20 years back, this has happened. Para 3, 28 years, planned for lap sterilization. After the procedure, patient had features of shock with breathlessness. Features of internal hemorrhage ruled out. And cardiologist was consulted and no evidence of any cardiac cause was attributed. And chest X-ray, when we find the chest X-ray, that revealed right-sided pneumothorax. And then immediately called to the cardiothoracic surgeon, chest tube was placed, patient recovered and discharged after 24 hours. This is a very unusual and atypical case and the brightest example of what is obstructive shock. Tension pneumothorax, obstructive shock. This is the brightest example I have seen, one case. Though tension pneumothorax is unusual following laparoscopic procedures, but few cases have been reported due to congenital small communication between the peritoneum and pleural cavity, right pleural cavity. This has been seen in the crux of the diaphragm. There could be some leakage, small opening where the gas can go and cause the pneumothorax for that. An appropriate diagnosis and chest tube placement saves life. 60 years, para 4 with precedencia, planned for vaginal hysterectomy with PFR. After pre-op evaluation and investigation, decided to do under spinal anesthesia. And within 2 minutes of spinal anesthesia, the anesthetist gave the drug, patient was apneic and totally BP pulse vanished and intubated immediately ventilated, the cardiac massage was given, pulse, BP and SpO2 stabilized after 5 minutes. And therefore, the anesthetist has done a very superb job in really resuscitating the patient, diagnosed as total spinal. Whether to do the surgery or postpone, how to prevent, how to manage. Perform the surgery, finished after 1 hour, patient was under ventilator and monitor, and after 3 hours, recovered spontaneously as the drug effect are abolished and transferred to ward. So this is one case. The total spinal is not uncommon. And this is again an example of distributive shock. This is one example of distributive shock where level higher up gives rise to difficulty in breathing and diminished SpO2. Managing the airway and oxygen support is a primary thing. Immediate management of intubation and ventilation will certainly stabilize the parameters. Once vitals is stabilized, surgery may be performed, and spontaneous recovery usually occurs after waning action of the anesthetic agents like xylocaine or bupivacaine for that. 26 years primary infertility. Under diagnostic hysterolaparoscopy, have done it. Under GA, surgical procedure was completed. Transferred to ward. After half an hour, emergency call from sister that patient is gasping. Pulse and BP not recordable. Immediate LMA was done with ambuvac ventilation was done, and SpO2 improved. Pulse BP stabilized after half an hour. Patient under observation with oxygen support for 3 hours. Stabilized, discharged after 24 hours. So this is an example of incomplete recovery. Very important to observe. Need for post-op recovery room with monitor. Early intervention saves life. And therefore I say minor or major, surgery for surgeons only. But for anesthetist, all are same. And remember, perioperative monitoring, if you do not do it, incomplete recovery can give rise to the peripheral circulatory failure and the apnea and cardiac arrest for that. 40 years para 2, planned for lap hysterectomy. Prophylactic antibiotic amoxicillin plus sulbactam given 1 hour before surgery. Immediate tachycardia, hypotension, sweating and altered sensorium with diminished SpO2. Bag and mask ventilation, hydrocortisone, IV fluids was given. And then injection adrenaline, 1 ml diluted in 10 ml of diluent, slowly IV given. And therefore, as adrenaline is given, pulse rate stabilized, BP improved with improved oxygen saturation. Patient felt better after half an hour. So this is a classical picture of anaphylactic reaction and a distributive shock. Adrenaline is the drug of choice, as I have already told. And as we give initially you think that it's a tachycardia, but how can I give it adrenaline? But absolutely this is an indication. Other supportive measures are necessary and even seen after test dose. 25 years, A2 with intramural myoma of 10 centimeter, planned for lap myomectomy. Vasopressin was the common agent where we give it 20 units and 100 ml of dilution injected locally. After 50 ml, bradycardia occurs. 40 per minute, BP fell down to systolic 50 but not recordable. And immediately atropine 1 ml was given. Only atropine 1 ml was IV given. The stabilized procedure was completed. So vasopressin is thought to be a very dangerous drug, and the consequences by causing a shock in intraoperative period. So before injecting the vasopressin, ask the anesthetist to be vigilant. The bradycardia is important, and this is a very preventable. Early injection of atropine can solve the problem. I think this is a very important. If you delay it, I think once it goes to the decompensated phase, then nothing can save it. So vasopressin is a panicky for gynecologists. Inform anesthesia while injecting vasopressin, and correct dilution is necessary, of course, and atropine is the answer. In the right time, if you give it, patient is saved. 33 years second infertility with history of lap surgery for tubal pregnancy left with acute pain abdomen, planned for diagnostic and therapeutic lap. There was an extensive pelvic adhesion and omental adhesion to anterior parietes. Adhesolysis done. Right salpingo-ovariolisis done. Left ovary cystic, adherent to gut and omentum, ovariolisis left done. POD cleared, uterus, left ovary, right adnexa, anatomy restored. Patient developed abdominal distension and pain on third post-op day. On examination, looks sick, tachycardia, BP 90/60, urine output 1000 ml per 24 hours, abdominal distension, tenderness, Antibiotics changed to meropenem, IV fluid, nasogastric aspiration, surgical consultation done to be reviewed after 48 hours. Patient didn't improve, developed jaundice, altered sensorium, TLC 30,000, neutrophil 85%, and the serum urea and creatinine increased, left LFT altered. Sonography fluid with echogenic contents in the paracolligator and peritoneal fluid. Decision for exploratory laparotomy done, but patient expired before surgical intervention. This is an unrecognized gut injury, leads to unfavorable post-op outcome. Early surgical intervention could possibly prevent such mishap. And therefore, my dear gynecologist, think about it. If the patient doesn't improve and there is abdominal signs, I think early intervention is important. And just do that and do a surgical intervention of drainage and at least suture the rent. I think this can save a life. I have seen these cases can be really, if early intervention is done, the life is saved and you can have a good post-op period for that. 25 years abortion 2 with submucous myoma, uterus grade 2, planned for transcervical resection of myoma, hysteroscopic resection with monopolar resectoscope. I'm telling about 15 years back when I was using monopolar resectoscope and under spinal with glycine as a medium. The fluid deficit was 500 ml only. I'm very cautious. Above 500 ml, I'm really cautious, not going to 750. Patient was irritable, altered sensorium, tachycardia, hypotension. So that gives me an idea that you stop the procedure. So by that time, partial resection was done, but operation postponed. Immediately, Lasix was given, injection mannitol, sodium bicarbonate, oxygen support with airway mobilization, and patient was stable after 8 hours. So don't continue the procedures to complete the procedure once the symptoms appear. You can do it in subsequent sitting for that. And more important, when glycine is being used, it is a dangerous drug. It can have ammonia toxicity, and the fluid deficit more than 750 ml is precarious for that. So glycine toxicity is known adverse reaction, bipolar restriction, and age over glycine toxicity, fluid deficit, recognizing the cause and abandoning the procedure saves life. And one of the advantages is that if you go for a spinal anesthesia, the patient will say earliest the symptoms will be manifested, rather than if you compare with the GA. And therefore, we changed from nowadays for the last couple of years, 10 years or so, we have switched from the unipolar to bipolar, from glycine to normal saline medium. So A3 all spontaneous first trimester abortions with history of tubal surgery, submucous myoma, planned for PCRM under GA with normal saline as a medium with bipolar resectoscope. So I thought the bipolar is safer. Procedure completed, but SpO2 is diminished, Krebs both long fields, and there was a fluid from the tube. Tachycardia, hypotension, decreased SpO2, and Krebs both long fields. Typical example of acute pulmonary edema. And Lasix 4 ampoules IV given immediately, indwelling catheter given, positive pressure ventilation given, 1.5 liters of urine drained within half an hour, and on ventilators for 4 hours. SpO2 increased, Krebs disappear after 4 hours for that. So don't think that bipolar resectoscope is safer than the unipolar. It is safer that it doesn't cause ammonia toxicity, but it may cause acute pulmonary edema. So the fluid deficit is important. More than 750 ml of glycine or more than 2,500 liters of normal saline equivalent. In one case, in glycine, there could be ammonia toxicity, but in normal saline, there could be acute pulmonary edema because the fluid deficit, if it crosses more than 2.5 liters, from the acute pulmonary edema is also a possibility. And that early detection and treatment can save the life of this particular thing. So acute pulmonary edema due to acute fluid overload occurs in bipolar resection. Fluid deficit of more than 2.5 liters gives rise to this condition. Early recognition, abandoning the procedure, or surgery in second sitting can help the patient as well as the surgeon. And diuretics, oxygen support, and post-op ventilation saves life. This is another 54 years, obese, hypertension, diabetes mellitus with carcinoma endometrium, stage 1 CA endometrium. Underwent lap hysterectomy. After 24 hours, she was dyspneic, tachycardia, BP was 80/50, oliguria, occasional Krebs, both long fields. And what could be the cause? Whether it's an early septicemia, whether it's an internal hemorrhage, whether it's an early pulmonary embolism. And hemoglobin came 10.6 gram, TLC 14,000, chest X-ray mottling patches, both long fields. And therefore, I diagnosed that this is a case of early pulmonary embolism. Oxygen mask, low molecular weight heparin, 40 subcutaneous BD, antibiotics, meropenem, hydrocortisone. Patient improved after 24 hours, vital stable, low molecular weight heparin continued for 5 days, along with antibiotics, IV fluids for 48 hours, stabilized after 48 hours. So the message is pulmonary embolism not uncommon in pelvic surgery. Prophylactic low molecular weight heparin is a place, definitely, and early intervention improves the condition. So think about it. This is also a place where embolism is a possibility, and this is a brightest example again of obstructive shock. 45 years underwent vaginal hysterectomy with PFR for procedencia. Third post-op day, tachycardia, hypotension, oliguria, and pyrexia. Pallor mild, increased temperature, mildly altered sensorium, abdomen soft distension. Antibiotics changed to piperacillin tazobactam, CBC, leukocytosis with neutrophilia. Patient didn't improve on the fourth post-op day. Ultrasound abdomen pelvic reveals echogenic area in the pelvis with fine echoes. And therefore, I thought there could be a source, there could be a collection of pus there. And drainage through the vaginal route. With the same, I think the vault, I punctured it, drainage through the vaginal route. I punctured it and find a drain, about 500 ml of thick pus was drained. Treatment continued as above. Patient have a significant improvement after 12 hours of drainage because the source is removed. Then the antibiotics can help. Vital, stable, discharged after 1 week. So this is a post-op sepsis and septic shock as a cause of shock, which you must diagnose and treat it on the 3 main principles: supportive treatment, pressure agents, and antibiotics, broad spectrum antibiotics, and tackling the source. I think if you do not drain it surgically, I think the sepsis is not going to be controlled for that. So need for likely septic focus and surgical intervention. Only medical intervention doesn't help. 43 years, para 2, both spontaneous vaginal delivery, abnormal uterine bleeding, adenomyosis, planned for vaginal hysterectomy. And vaginal hysterectomy under spinal anesthesia was done 12 hours following surgery. I found tachycardia, hypotension, 80/50, abdominal distension, pain abdomen, pallor plus. So immediately I thought there could be a possibility of internal hemorrhage and subjected to laparoscopy. There was hemoperitoneum, blood and blood clots removed, active bleeder from the right pedicle, partial slippage of suture, bipolar coagulation done, hemostasis maintained, post-op uneventful. So post-op internal hemorrhage giving rise to hemorrhagic shock is a preventable event. Very meticulous surgical technique is required with special reference to hemostasis during previous surgery. Slippage of pedicle suture from upper pedicle is the cause of bleeding. And early diagnosis, clinical suspicion, and emergency intervention is the key. Otherwise, you lose the patient. 46 years, underwent lap hysterectomy for multiple myoma uterus, discharged on 3rd post-op day. Presented with acute onset of severe bleeding PV, tachycardia, hypotension, tachypnea. Resuscitation started, abdomen soft, evidence of peripheral circulatory failure, active bleeding PV, planned for exploration under anesthesia. Post-speculum clots in vagina removed, active bleeders from the margins of the vault form. And earlier, in our student days, when the patient presented with secondary hemorrhage following hysterectomy, you give a vaginal pack. I think don't give a pack for that. You inspect it. Where is the site of bleeding? That's a paramount importance for that. And if you find an active bleeder, then suture it. If you do not find it a general, then you pack and other things can help it for that. So here we find an active bleeding from margins of the vault found to be open, repair a vault with hemostasis, patient discharged on 3rd post-op day. So post-op hemorrhage following hysterectomy, not uncommon, usually presents with small bleeds for few days, controlled with styptics and antibiotics, mainly due to infection, hard stool, or excessive physical activity. Massive bleeding of acute onset is a rare presentation. In this particular case, it was a sexual act. I found out following that a sexual act. Immediate exploration repair with hemostasis saves life. Vaginal approach is feasible. Post-op counseling and advice is necessary. But the incidence of secondary hemorrhage or even in the reactionary hemorrhage could be solved if a primary procedure is well taken. The careful angle closure with the vault fixation and the vault closure with hemostasis is of paramount importance. And you find I think by that you adopt that, you do not find a case of postoperative hemorrhage for that. 45 years para 2, both spontaneous vaginal delivery with multiple myoma uterus and cholelithiasis, planned for lap call and vaginal hysterectomy in the same sitting by the surgeon doing a lap call, and I will do the vaginal hysterectomy. After detailed pre-op evaluation, both procedures were completed. Uneventful intraoperative period and postoperative period. Planned for discharge. Patient was about to discharge. Patient was absolutely fine. The bowel bladder was moved. She was normally taking food. On 4th post-op day, on the day of discharge in the morning, early morning, patient had an episode of loose motion and fell down in the toilet. On examination, patient was gasping. BP not recordable, pulse not palpable, heart rate irregular, 100 per minute. Immediate intubation and ventilator support was given, transport to ICU, and blood sample sent for Trop T. Cardiologist consulted, and cardiac arrest after 20 minutes could not be revived, but it was Trop T positive. Later, the report came as a Trop T positive. So, classical example of cardiogenic shock. But the unfortunate thing is that this happened on the day of discharge. Even with normal pre-op cardiac evaluation, such event can occur in the perioperative period. So therefore, the detail, if they're at-risk women in the pre-op evaluation, you should not restrict only to the elect ECG. You should do a more elaborate investigation. But in normal cases, whether elaborate investigation, cardiological investigation has to be done is a big question mark. Acute myocardial infarction and massive pulmonary embolism could be the differential diagnosis here. But Trop T and chest X-ray could give some guide. And here, the Trop T was positive, and retrospectively, we diagnosed that this is a case of the acute myocardial infarction. Fatalities occur even with aggressive management and all that. And this happens, and the shock in the perioperative period, both in obstetrics and gynecology, can give a challenge to the gynecologist. And really, one should be open-minded. One should realize the fundamental principles and the physiology of the shock and its consequences, and try to manage it at your own level. And as and when required, you can take help from the other people. Thank you very much, ladies and gentlemen, and my dear team members from Juventus. Thank you.
Thank you very much, sir, for your very informative and knowledgeable lecture. Sir, with your permission, we can take the questions, sir.
Yeah.
Yes. So the questions are very interesting. Dr. Indira Gupta from Khargon, MP, she is discussing of one case. She is saying that the patient got convulsions after LSCS, post-LSCS. No history of PIH, no medical problem post-LSCS, and the convulsion management done and shifted to ICU. Sir, I could not understand the cause of convulsion, anesthesia problem, or the other cause. Please discuss, sir. Explain, sir.
Well, I think this case should be followed up. I should know what could be the sequence of when. If you sent to ICU, what has happened to the patient? That's important, because there could be coincident finding. I remember one case after surgery, the third day after surgery, patient had a convulsion. Immediately, yeah.
Yes, sir.
Mute. Yes, sir.
So this particular case, she has again a convulsion. I immediately did a CT MRI. I could find internal hemorrhage. So internal hemorrhage could be a cause for that. That's there. Maybe that a berry aneurysm has ruptured and it's a coincidence during the surgery. That could be another find for that. You first rule out whether it is of gynecologist or obstetric importance. Say, for example, in cesarean, we must think that if there is a convulsion, we think PIH is the first thing for that. But if PIH is ruled out and you find out that on CT MRI, you find out some of the cause, and then appropriate intervention has to be done. The commonest thing I have found, intracerebral hemorrhage following that in surgery. It is a coincidence for that.
Yes, sir.
Yes, sir. There are many compliments also from Dr. Rita Malik. She is saying excellent lecture and great salute to you. There is another question, sir, from Girija. She is asking how much vacuum pressure required for a head delivery during CS?
Cesarean section.
How much?
How much vacuum pressure?
Oh, vacuum pressure. See, earlier the vacuum which was a Maelstrom divide is a metallic vacuum where the chignon is being used. That was not advised for cesarean section. That was used for a vaginal delivery, and a chignon has to be developed on the fetal scalp. Now in the celastic cup, the chignon method is not adopted. It can be connected directly to the normal vacuum, and about 400 to 600 is enough for that. And you can know as long as the vacuum cup is holding tightly to the cup, that is the desired limit for that, and usually that is about 300 to 400.
Yes, sir. So the next question is from Dr. Sarita Agrawal. She is referring to one of your case involving oxytocin. She is saying that it can be a myocardial effect of a large dose of oxytocin, not actually the anaphylaxis.
Yes, the anaphylaxis occurs with a small dose, but if you give a more than, therefore recommended is don't give 5 units of oxytocin intravenously more than 5 units. So it's not recommended to give a 10 units of oxytocin. If you divide 5 units IV and 5 units to the drip, that was recommended by WHO as a preventive measures as an ecbolic for that. So more than there's a dose related, the oxytocin as a myocardial vascular constricting agent, myocardial vessels that constricts, and that is dose related, and therefore it is not an anaphylaxis. I fully agree with you that it's not a question of anaphylaxis, but if it occurs immediately after that giving that, and it could be the drug reactions could be that, but it could be the directly cardiotoxic effect of the oxytocin that has been reported also.
Yes,
sir. Next question is from Purnima Nepram. She is asking how to manage a case of cesarean scar pregnancy who wants to abort.
We have discussed the cesarean scar pregnancy in ectopic pregnancy episode, where I have told that the cesarean scar pregnancy, first of all, the diagnosis should be very, very important. There are a lot of pitfalls in diagnosis of cesarean scar pregnancy. The problem of cesarean scar pregnancy is the bleeding following that event. If you have done an evacuation or a procedure, immediately you remove it, then there could be bleeding continuing for that. And that is the only risk. So the option, there are surgical methods and medical methods. In medical methods, you can give a methotrexate and the misoprostol. That's one aspect. Or in the surgical methods, you can go for a laparoscopic exposure, correct it, scar, excise the scar, remove this product, and then seal it with that. Another literature should, I don't have an experience on hysteroscopic approach, where it has been mentioned that hysteroscopic approach, where you have to, prior to hysteroscopy, you have to find out the thickness of the uterus from the bladder in the lower part, in the cervix. If it is more than, if it is less than 3 millimeter, don't attempt hysteroscopy. Otherwise, it will be hazardous. If it is more than 3 millimeter, you could do a hysteroscopic resection and then roller ball and then Foley's catheter as a tamponade and do the procedure for that. This is 2 surgical methods for that. And medical methods you adopt for the methotrexate and the misoprostol.
Yes, sir. So the next question is from Dr. Preeti Malhotra. She is from Udaipur, and she is asking your advice regarding the fluid management in the shock.
Fluid management in the shock, I have already told, particularly for the crystal, for the hemorrhagic shock, the fluid management in class 1 and class 2 crystalloids. In class 3 and class 4, always in the blood transfusion along with the crystallology necessary for that.
Kedar.
Yes, Dr. Tarika is asking regarding causes of shock.
I've told the causes of shock I've divided into 4 different varieties: hemorrhagic shock, distributive shock, obstructive shock, and cardiogenic shock.
Yes, sir.
Yes, sir.
Dr. Alka Kute from Amravati. She is asking the previous two LSCS with first D and E for missed, and now the patient comes with 11.2 weeks gestation with twin gestation. So question, I didn't get it, sir. She has written that much only.
11.2 weeks pregnancy and with the previous two cesarean section.
Yes, sir. Yes, sir.
What to do? What is your purpose? You have to continue the pregnancy or terminate the pregnancy? If you want to terminate, I think better that you continue the pregnancy.
So she is asking for MTP.
MTP. And I think it's a better say that yes, you should continue the pregnancy and then do a concurrent sterilization, because 11.2 is a borderline case where there is a risk of evacuation for that also. But if at all she is insisting on that, you can go with the termination pregnancy with a prior misoprostol administration and then do an evacuation. That can be done with that.
Yes, sir. Correct, sir. So the next question is from Asisha Ranjan Mohanty. She is from Keonjhar. She is asking in which situation there is a possibility of amniotic fluid embolism.
Well, theoretically, amniotic fluid embolism is mainly it's a misnomer. I think nothing known clear-cut picture is known for amniotic fluid embolism. The main thing, it could be in a cesarean section following hydramnios, polyhydramnios, they go for that amniotic fluid embolism. Otherwise, the risk factor in a twin, the obesity and the polyhydramnios, these are the main three at-risk factors for amniotic fluid embolism for that.
So, sir, there are a number of admiring messages. I will just read out. Latika Shukla from Prayagraj, she is saying, thank you, sir, for your wide variety of cases discussed. Your presentation was an eye-opener and great help in the decision-making in our day-to-day practice. I look forward to more such topics being discussed. Sir, would you recommend echo in young patient with essential hypertension existing before pregnancy and continuing with IBP throughout the pregnancy?
What is that? What is that wrong?
Sir, she is asking, would you recommend echo in young patients?
Oh, echo, yeah. Say in a chronic hypertensive, I think it's a echocardiography is a mandatory thing for that. In a chronic hypertension, you do it. That is not a problem, because the ultimately we have seen in a young age also we find the ejection fraction, low ejection fraction in that particular, which could be detected much earlier, and caution has to be given as pregnancy advances.
Yes, sir. The Sheikh Mohammed from Anand Naik, he is paying regards to you. Pay my regards to Professor P C Mahapatra Sahib from a beautiful land of Kashmir. You are always in my prayers, and I pray for you long and peaceful life.
I will definitely visit. I will definitely visit your place. I have gone several times. I enjoyed. My gynecologists in Jammu and Kashmir are something special. I think they are something unique and special in contrast to other persons.
Yes, sir. Kedar?
Yes, I think there is another one question from Dr. Alka Kutheoni. With Foley's induction will be better option, and calling her after 4 to 5 weeks in previous patient with prior to LSCS.
Well, Alka, I think here in the previous two sections, the duration of gestation is important. You have really asking a question where a very tough decision has to be taken, 11.5 weeks. I think if it is a less than 10 weeks, it's all right. You can give this misoprostol evacuation could be better option for that. If it is a 12 weeks plus, I think don't adopt for the evacuation. You better go for the delayed method, like a priming with Follies, like a priming with misoprostol, and then take some time for that. Or you wait for 1 or 2 weeks, and then you can give a Follies extraamniotic saline infusion, and then subsequently evacuation has to be done. But these borderline cases, either you postpone it, 11.5, you make it after 1 week or 2 weeks, 1 week or 2 weeks after that, and start extraamniotic. That's much better for that. But evacuation at 11.5 is also difficult in the case of previous cesarean section, even if with misoprostol also. So in that particular case, if it is less than 10 weeks, I will definitely go for surgical evacuation with misoprostol. If it is 10 to 12 weeks, I will postpone it. And after 12 weeks, I will just give a extrametric Follies and then wait for that, and then I will do an evacuation.
Yes, sir. Dr. Sarita Agrawal from Raipur and Priya Sengania from Purulia. They are thanking you. Dr. Mahapatra, teacher par excellence, teaching all practical tips and excellent case scenario. Thank you so much, sir.
I'm happy that Sarita, being a professor and head of the department in All India Institute, she is very knowledgeable and a teacher par excellence, and she is overestimating me. I love Sarita too much for that, and I wish to visit Raipur very soon. Thank you.
Yes, sir. Thank you, sir. So that's all, sir.
That's all.
Thank you.
Thank you very much, sir. Thank you.
Thank you.
Thank you very much, sir.
Close. I think today we are on
Thank
time.
you.
Thank you very much, sir.
Thank you.
Thank you, sir.
Thank you.
Thank you
The
very
recording
much.
is stopped.
Thank you.